Good morning, ladies and gentlemen. Good afternoon. It's afternoon. My name is Marcia Gordon. I'm the president and CEO of the Business Council of Westchester, for those people on that I may not know. And we at the Business Council are dedicated to working with businesses to build our community, to have businesses prosper, to have our community prosper, and especially during the pandemic. We have been the advocate, we have been the connector, and we have been the information provider and the information resource for the business community in Westchester and beyond. And it's my pleasure to have with us today a wonderful member, a wonderful topic, the professionals from Orthopedic and Neurosurgery Specialists, better known as ONS. And ONS has been providing the highest standard of comprehensive orthopedic and spine care to residents of Westchester and Fairfield counties for more than 20 years. The practice has 26 fellowship-trained specialists. By the way, my husband has been to 3 of the wonderful doctors at its offices in Harrison and Greenwich in Stamford, Connecticut, who are ranked as top doctors and rising stars in the region by Castle Connolly. ONS physicians have a collaborative approach to care that focuses on a patient's personal recovery goal. ONS offers state-of-the-art physical therapy centers, urgent ortho care, and digital imaging at all locations, and MRI in Greenwich and Stamford. Learn more at onsmd.com. And today's topic is for a lot of us, including me, because I just returned to working out after a year, the reality of fitness after a virtual year. How many of us put in the chat box? For how many people is this very, very relevant? And what I'm going to do is I'm going to introduce one speaker at a time. We will take questions at the end. So again, please use the Q&A box or the chat box. And I'm very glad to first introduce Dr. Mark Kowalski, sports medicine specialist, specializes in shoulder, elbow, and knee. He's a surgeon at ONS. He's a board certified orthopedic surgeon with a subspecialty, as I said, in sports medicine by the American Board of Orthopedic Surgery. He completed 2 subspecialty fellowships, the first in sports medicine at Lenox Hill Hospital, Nicholas Institute of Sports Medicine and Athletic Trauma, and the second in shoulder and elbow surgery at the Washington University School of Medicine. He has expertise in the surgery and non-surgical management of sports injury of the shoulder, elbow, and knee. He treats complex shoulder and elbow conditions, including degenerative disease, trauma, and revision surgery. Dr. Mark, I'm going to turn it over to you to start.
Great. Thank you so much, Marcia, for that introduction. I'm going to take a minute to share my screen with everybody, and just let me know if it's not showing up. I couldn't think of a better time to cover this topic. I was walking from the car to the office just now. It's 65 degrees and sunny, and I know we're all itching to get outside and start exercising again after what seemed like an endless winter under 3 feet of snow and ice. So I think we're all going to touch on the different ways that we all might be at increased risk of injury in various joints and parts of our bodies, and what we can all do to avoid injury as we get back to sport. So I'm going to spend some time talking a little bit about the shoulder, and then I'll pass it on to my colleagues. In general, I think the health benefits of physical activity are widely documented. And I think what some people may not appreciate is that the benefits of exercise extend far beyond orthopedic and bone and joint health. Obviously, there's cardiovascular benefits and a significant decrease in overall mortality. Diabetes and other metabolic disorders are significantly improved through exercise. there are clearly documented mental and neurological health benefits as well. And obviously, the bone health benefits of weight bearing exercise are widely known. I think what we're now beginning to appreciate after more than a year of shutdown and a significant impact on what otherwise were our exercise routines are the effects of the pandemic related inactivity. So we all have experienced a certain amount of deconditioning, both in terms of our heart health and pulmonary lung function. We can all undergo a certain amount of atrophy or loss of muscle mass throughout our bodies. As a result, our ability of our muscles to participate in endurance activities is diminished. I think in the recent press, there's been some intention on weight gain and increase in body mass index that's occurred over the past 12 months. As we kind of let our stretching routines lax, our joints become increasingly stiff. And as a result of all of these phenomena, we end up at being at increased risk of injury throughout our bodies. And it's something that obviously we're going to experience as we get back to sports. Ironically, the battlefront that we often find ourselves in our day-to-day practice before the pandemic was the battlefront of overuse. We're often counseling, particularly our young athletes, but also our older recreational athletes, about the pitfalls of participating in too many sports at once and the pitfalls of not allowing enough time for recuperation. And we found ourselves on the other end of this seesaw now with 12 months of pandemic related inactivity, where we have all of these effects of underuse. And we're really trying to balance this seesaw and thread that needle between these two extremes. But before we find that balance, we have to reconcile the consequences of overuse that we've experienced. The shoulder is uniquely susceptible to injury and is a very common reason for patients to come to our office. So shoulder pain accounts for about 16% of all musculoskeletal complaints. It's the second most common complaint of a patient presenting to their primary care physician. And about 1 out of every 5 patients will suffer from some type of shoulder pain during their lifetime. And this was before the pandemic and the related inactivity even occurred. Just some brief words about the anatomy of the shoulder. It's a very complicated joint, and it's a joint that differs from the rest of the body in significant ways. The joint is really made up of the humeral head, or the ball, which is attached to the upper part of the humerus bone, and also the socket, which is a part of the shoulder blade. And in contrast to other joints of the body, it's a very unstable joint by design. You see that the ball is very large and the socket is very shallow and flat. So it's really not a concentric fit like the hip or knee might be. It's unstable by design so that we can have flexibility and place our arm anywhere in space. But as a consequence, the joint relies more on muscles for balance than other joints in the body. As with any other joint in the body, though, the ends of the bones are covered by this pearly white cartilage cap. This is a very specialized tissue that allows for friction-free gliding of one bony surface on another. And it's this surface that tends to break down in patients that develop some degree of osteoarthritis. The most important structures of the shoulder joint are the muscles of the rotator cuff, and these are very common culprits of shoulder pain. The rotator cuff consists of 4 muscles that originate on the shoulder blade and then make their way out towards the humerus as they cross the joint. And these 4 muscles fuse to form this single rotator cuff tendon that attaches to the humerus immediately behind the ball. Now, these rotator cuff muscles clearly provide strength when we're performing activities away from the body and above shoulder level. So that is certainly true. But the more important function of the rotator cuff is to maintain balance of the joint. We talked about how the joint is unstable by design. And because it's unstable, it relies on muscles to maintain a stable connection between ball and socket. And when these muscles atrophy, become weak, or become fatigued, they lose their ability to maintain that balance. And that's a common reason for patients to develop pain as a result of overuse. So these are the various structures that can create pain in the shoulder. This is a cross section of the shoulder joint and all of the surrounding structures. And these red circles indicate all of the different reasons patients present to us in pain. And I've highlighted the three most common causes. Joint arthritis or glenohumeral arthritis, where the cartilage begins to break down, is a very common cause to present to us with pain. And tendinitis or inflammation of the adjacent bursa, also known as bursitis, is an extremely common cause of pain. This is more of a three-dimensional view of the same area of the body. And we see again this bursa, which can become inflamed in people that are performing repetitive activities. And the one structure that we also see in this illustration is the biceps tendon. Most patients don't realize that the biceps tendon is a part of shoulder anatomy. We all clearly understand the biceps muscle. It's lower down on the arm. It's very prominent. It's immediately beneath the skin. And we see the biceps contract when we perform elbow flexion maneuvers through sports or with weight training. But as that muscle travels up towards the upper arm, it becomes the biceps tendon. And that biceps tendon actually travels immediately adjacent to the rotator cuff. It then penetrates the joint and attaches to the inside of the shoulder joint. And this biceps tendon is a very common cause of pain in the shoulder as a result of overuse. There are a variety of different pieces of information we use to try to determine what the cause of a patient's shoulder pain might be, from their age and occupation, the nature and intensity of their pain, things that make the pain worse or better, whether there was trauma involved in their episode of pain. But the single most common or the single most helpful piece of information that helps us hone in on the possible cause of pain is the location of pain. The orthopedics tends to be very simple. The first question we ask is, where does it hurt and what lives there anatomically? And what we find is that that can clue us into the possible cause of pain. As I've mentioned, the biceps tendon travels in the front of the shoulder and therefore creates pain right there in the front part of the shoulder. The rotator cuff tendon and the adjacent bursa, when those become inflamed, tend to create pain on the side of the arm between shoulder and elbow. And things like labrum tears or joint surface arthritis tend to create pain deep within the shoulder and can be associated with clicking and catching. So location of pain is an exceedingly important clue as to what might be going on. But the history is also important, and regardless of what type of pain a patient might be experiencing, the history can be fairly similar. There is often a history of overuse, which is what we might see over the next few months as patients get back into their springtime sports and activities. There's often night pain that interferes with sleep. There can be associated weakness that can either be true weakness because the tendon might be torn, or pain-mediated weakness because the tendon is inflamed. The joint can become stiff because as a joint becomes painful, we want to move it less. And as we avoid the extremes of motion, our shoulder becomes stiff over time. And patients will often describe difficulties with activities of daily living, like combing your hair, snapping your bra strap in the back, or threading a belt loop, or with heavy lifting. Well, I'll pause for a minute and just point out that this is kind of how a typical orthopedic presentation might look. We've talked about anatomy. We've talked about the anatomy and the mechanics of the joint. We've begun to talk about symptoms of pain, and then I would normally go on to describe what the examination might look like, and then the different kinds of surgical procedures we might use to make that patient better. But we want to change the pattern with this particular presentation, and we're trying to counsel our audience today on ways that we can prevent injury from occurring in the first place so that we don't go down the cascade of developing a problem that might require more invasive treatments like injections or medications or even surgical intervention. So in terms of the risk of surgery, this is what the vicious cycle tends to look like for a lot of the overuse injuries that we encounter. First, there's underuse, as we've talked about, in this case, due to the pandemic and the related inactivity. This underuse tends to create certain risk factors, and these risk factors can then lead to injury. When a shoulder becomes injured, the patient is therefore unable to exercise, and that underuse or disuse becomes even worse, and the vicious cycle continues. The risk factors that are most important in the development of shoulder problems include these three: shoulder stiffness, number one, loss of motion; rotator cuff weakness, number two, those important muscles that maintain balance to the joint; and the third, the less commonly discussed, is an abnormality of the shoulder blade mechanics, abnormal shoulder blade movement. This is an also exceedingly important part of why patients develop shoulder problems. And we can do a little bit to mitigate each of these three risk factors. So the first is shoulder stiffness. As I've mentioned before, the shoulder is unstable by design so that we can move it anywhere in space. We have pretty tremendous shoulder range of motion. We can abduct or elevate almost up to 180 degrees. And we can externally rotate almost, 70 or 80 degrees. And we can internally rotate in order to place our arm almost all the way up on our back. But when patients develop painful conditions of the shoulder, they tend to lose some of this motion, which can make them even more predisposed to developing an injury. So we want to try to advise our patients on simple home exercises that can address shoulder stiffness. And here's three examples. The first panel is demonstrating what we call a table slide. You sit in front of a table, ideally with a smooth surface. You place your hand on the table. You can even use a tablecloth between your hand and the table to make it even more slippery. And you simply lean into it in order to bring your arm into more and more forward elevation. This is a closed chain exercise because your hand is resting on a surface, so there's more stability here, which allows it to be a little bit less painful. And it allows you to stretch that shoulder joint in order to gain more forward elevation. A more advanced form of this is the so-called wall climb, and you can see that in the middle panel, where a patient is simply walking their way up the wall until they get to the point where they're beginning to stretch that arm into forward elevation, and they can even lean into the wall a little bit to gain additional motion. The final two are internal rotation stretches. One is using a towel behind your back, and you're using the upper arm to pull the lower arm into more and more internal rotation. And the bottom right panel is demonstrating a cross-body stretch where you pull the arm across your body, stretching the posterior capsule or the capsule in the back of the joint. These are 4 easy stretches that you can do on your own. And I recommend that you do each of them for 30 seconds, each for 3 repetitions, in order to make sure you're maintaining motion in each of these planes. Shoulder weakness is another important risk factor for injury. And we see on these top 3 panels how we typically measure strength in 3 different planes: elevation, external rotation to the outside, and internal rotation to the inside. And we can often observe frank weakness on examination, but sometimes the weakness can be subtle. In baseball players or tennis players, they may not necessarily describe true weakness, but they may simply describe a so-called dead arm sensation where they just sort of, the arm feels dead at the end of participation, and that's another version of weakness. So what can we do about the weakness? Well, we can do some simple strengthening exercises that really don't require any significant equipment. Simple TheraBands or exercise bands are enough, and we usually start with the least resistance band possible. The first panel is demonstrating an external rotation exercise, which will strengthen certain components of the rotator cuff. You attach the band to a rigid structure like a doorknob or a leg of a table, and you simply start from having your arm against your body, and you simply gently rotate externally until you get to the end of your range of movement, and you hold it there for a 5-second count, and then bring it back against your body. That's 1 repetition. And you can do 3 sets of 12 repetitions. The second panel is demonstrating the opposite direction. So this time the band is over there attached to a doorknob on the other side, and you're bringing instead now your shoulder into internal rotation until your shoulder arm is against your body, and then you're allowing it to come back out to the starting position. Same thing, 3 sets, 12 repetitions each. And finally, abduction or scaption, where you're bringing your arms in the plane of the scapula, which is about not straight out to the side, but 30 degrees towards the front. You have the bands attached below your feet, and you're simply raising your arms to the end range of your movement with your thumbs pointed up. Hold it for a 5-second count, and then bring it back down to your side. And again, three sets, 12 repetitions each. The final risk factor that we've talked about is motion of your shoulder blade. Without even knowing it, patients with a shoulder pain condition will often demonstrate a slight asymmetry in how the shoulder blade is positioned at rest and how the shoulder blade moves when the arm moves in space. This is a term called scapular dyskinesis, which simply means abnormal shoulder blade movement. It results from injury, and it also can increase the risk of a future injury. So it's important to address the muscles that attach to the shoulder blade. There are many of them. There's about 17 muscles that either originate or attach onto the shoulder blade, and we can work to strengthen these with some simple exercises. These are 2 examples. One is simply scapular retraction, where you just bring your shoulder blades back. You imagine you're trying to touch the backs of the shoulder blades together, and you hold it for a 10-second count and then relax. That's 1 repetition, and I would recommend 3 sets of 12 repetitions each. The next example is the so-called angel wing exercise, where you start in the position demonstrated there, bring your shoulder blades back as if the inside border of each is touching, and you simply bring your arms down to the side and then back up again, and that would be 1 repetition. And you would do 3 sets again of 12 reps. So in summary, the most common cause of shoulder pain is rotator cuff tendonitis or bursitis, as well as biceps tendonitis. The common risk factors for the development of pain conditions of the shoulder include shoulder stiffness, rotator cuff weakness, and abnormal shoulder blade movement. And a simple stretching and strengthening program that I've described here for the rotator cuff and for the shoulder blade can decrease the risk of injury as we all get back to sports after prolonged inactivity. So for more information, our website has some of this information. The Orthopedic Academy at orthoinfo.aaos.org has some great information, as does our sports society. So with that, I'm going to hand it back and let my colleagues talk a little bit more about.
I'm still busy stretching, doctor. That was my favorite part. That was my favorite part. Very, very interesting, very insightful. I'm sure a lot of us can relate to some of those physical feelings. And moving on, I'm pleased to introduce Dr. Alex Levchenko, who's an interventional, did I say that right?
Yep.
Physiatrist, sports and spine medicine for ONS. He's a board certified, fellowship trained physiatrist. He specializes in the non-operative treatment of spine, joint, and muscle pain, with an emphasis on image-guided interventional procedures using steroidal medications. Okay, help me in with this visco supplementation and PRP, platelet-rich plasma. I tried. Dr. Levchenko's goal is to return patients safely to their best function through a comprehensive treatment protocol. This includes non-opioid medications, patient education, and physical therapy. He is an expert in performing such treatments as fluoroscope. Okay, you've got to do that one for me. Guided epidural steroid injections, facet joint injections, other joint injections, medial branch nerve blocks, radiofrequency ablations, and ultrasound guided musculoskeletal injections. Dr. Levchenko also performs electrodiagnostic studies, EMG. He is clearly an expert. We are very fortunate to have you today to talk about the reality of fitness after a virtual year. Doctor.
Well, thank you very much for your kind introduction. Hello, everybody. Good afternoon. Let me share my screen with you. Just 1 second here. There you go. And let's see. Okay, perfect. All right. So again, thank you for your kind words, your kind introduction. I'm Dr. Levchenko. I'm interventional physiatrist, pain management specialist here at ONS. I mainly spend my time in our Harrison office, but I also do go to a Greenwich office. Okay, so we're gonna get started without further ado. So we're gonna talk about spine. Spine is the backbone of the body. So a little bit of anatomy. It's made up of 33 bones. They're known as vertebrae. So little blocks stuck on top of one on top of another. There are 7 of them in the cervical or neck area, right? 12 in the thoracic or mid back, and then 5 in the lumbar, and then the rest are in the sacrum. You have discs, also known as shock absorbers. They sit in between the vertebrae, and you also, everything is surrounded by lots of ligaments and muscles, as you can see right here. And the ligaments and the muscles, they provide stability for the spine. You have little joints on the side. They're called facet joints, and they connect all of the segments of the spine together, and they allow for great mobility of the spine. The spinal cord passes right in the middle, just in the center of the spine. And then you have the spinal nerves that exit at each level, and they go in from the cervical spine, they travel down to your arms, and then from the lumbar spine, they go down to your legs. So if someone has a pinched nerve, sciatica kind of pain, those are the kind of nerves that usually get pinched. And you can see them here on the picture right there, the yellow nerves coming down. So back pain is very, very common. 31 million Americans suffer from back pain at any given time. And 80% of Americans will suffer at least one episode of back pain in their lifetime. So it's very common. So this last year has been a challenge. Lots of us have been working from home. That means no commuting. We're not getting out. We're not walking to the train, to the bus, to our cars. We're at home, right? So less walking, sitting more. And generally what happens with decrease in activity, you have increase in musculoskeletal pain, including neck and back pain. Now, the year has been very, very stressful, right? And stress also is a known risk factor for neck and back pain. Poor ergonomics, right? You're working at the kitchen table, you're working on the couch, you're working on your bed. You don't have the same desk and computer set up as you have at work. And that can present a whole other source of problem. And then the prolonged sitting in general, right? The muscles get weak and they get tight. Including the stabilizing muscles in the back that we saw on the previous slide, but also the hamstrings and the hip flexors. So what's the next step? What can we do? Well, becoming more active, even if just going for a walk, right? The studies show, the literature shows that taking a walk every day helps to strengthen the muscles, keeps the bones healthy, reduces the pain, and prolongs the life of joints. So it's a great starting point. And exercise has positive effect both on musculoskeletal pain and stiffness, as well as in the cardiovascular fitness, right? Stretching, incorporate stretching into your routine. And then definitely try to address the poor ergonomics, right? So setting up, having a good setup at home for your work place is very, very important. So proper desk, chair, and computer setup, and we'll talk about that. And then avoid working on the bed or on the couch. That's just a bad setup there. All right, so how much exercise, right? So the benefits of exercise far, far outweigh any risks associated with it. Now, if you do have a health condition, then by all means, definitely talk to your primary care physician and get a clearance that you're okay to go and start exercising. But if you're generally healthy, the American College of Sports Medicine recommend moderate intensity, at least 30 minutes per day, at least 5 times per week, right? Or you can do a more high intensity training, and that usually can be 20 minutes is enough, 3 times per week. And then you can combine either, right? So you have a combination of the above. Now, the resistance training is also very, very important, right? As we're getting a little bit older, we start losing the muscle mass. So the resistance exercises, try to fit in 2 or 3 times per week as well. And then don't forget about stretching, right? Those tight hip flexors, tight hamstrings. So again, try to stretch at least twice per week. And you got to hold each stretch. You got to give it time, right? You got to hold it for at least 60 seconds to get a desired benefit. Now, if you say, look, I can't, right? I'm deconditioned. I can't do it. I can't do 30 minutes. That's okay. Start with 20 minutes, right? And if you're really deconditioned, start with 10. That's okay. Start with walking. Shoot for 7,000 steps or more per day. That's a great start, right? So now the exercise, right, and especially resistance training, they're effective in to prevent and treat metabolic syndrome, right? So what's a metabolic syndrome? Well, it's actually a combination of high blood pressure, high cholesterol, triglycerides, high sugars, right? And as well as the increased waist size, right? So increased fat around the waist. And then that's actually a very known risk factor for severe COVID. So protect yourself. Exercise also decreases stress, helps improve depression, anxiety, and sleep. And in fact, actually, if you are suffering from fatigue, the exercise, a good regular exercise, can help decrease the fatigue. So here's an example of proper ergonomic setup, right? So you can alternate between sitting and standing. You want your eyes hit the monitor at about 2 inches below the top of the monitor. You want to have your elbows bent and kind of flow through the wrist and into the keyboard. You want to rest your feet on the floor or on a little stool. Generally, you want your thighs to be either parallel to the floor or just a little bit higher, right? So the knees could be slightly higher than the hips. And as I said, changing the position, alternating can give you exercise and can help you move around a little bit more, right? So, and yes, so using a wire. So if you're working on the laptop, definitely get a wireless mouse, a separate external monitor, a wireless keyboard. And that can really, really help you as well to alleviate a lot of tension and in your neck and the upper back area. Now I get asked, can I sit on an exercise ball? Yes, you can, right? We don't recommend sitting all day on the exercise ball. So you can alternate, right? And you can send maybe 15 to 20 minutes at a time. That's all right. But other than that, it creates a lot of instability and it can actually create more problem going forward. But 15, 20 minutes at a time, totally fine. Now, how heavy is your head, right? So the cell phone neck, right? So our heads are usually about 12 pounds, right? So, but if you forward, the gravity adds on the pull onto your head. And as you can see on the picture right here, even 2 inches forward, all of a sudden your head weighs 32 pounds, right? And that creates lots and lots of stress and tension for your neck and then your upper back, and then create, that puts you also at a disadvantage with your shoulders. So you end up with round forward shoulders, and that destabilizes your shoulder joint, as Dr. Kowalski was describing in his talk, right? So that can lead to a whole host of other problems, such as impingement syndrome in the shoulder. All right, so what can we do? Exercises. So I like Dr. Stuart McGill. He's developed a very, very simple 3 exercise program, right? So he's actually professor of spine biomechanics in Canada. He's written a few books. You can look him up on Amazon. Terrific. Lots and lots of information. So he's actually talking about not just building the core strength, but also building the endurance. And he has 3 simple exercises. Most of you know those exercises. You start, and by the way, so just take a note, write down McGill Big 3, and you can put it in Google, and it will spit out all of that information for you, just how to do the exercise. There are lots of videos online as well. But generally, you start with 3 sets. You start with a higher number of reps, and then you decrease as you're progressing through your sets. And then you increase the reps as your endurance improves with the exercise. But pretty much it's the curl up, it's the bird dog, and it's the side bridge. All right, those are the 3 exercises, very simple, but very effective. Okay, and stretches. Okay, so stretches. So right here you have on the left, you have the elevated cap, terrific stretch. It stretches your capsule, it stretches your shoulders, it stretches your pectoralis muscles, right? So opens up your chest and gives you great stretch for the upper back and the shoulders. If that's too hard, right, you can do the stretch right below, just behind the back, right, a little stretch right there, or even just grabbing, if you have a pull-up bar, jump up, grab the bar, and just hang with that weight. That stretches your upper back, stretches your pectoralis, stretches your shoulders, and repositions, resets your rotator cuff, right? The table is a great stretch, also stretches your biceps, all right, and strengthens your elbows and stretches your wrists, but it's a more advanced version. So if you're having some pain or it's difficult, that's definitely not the stretch to start with. But if you're already pretty flexible, that's a great stretch to incorporate into your routine. All right, my favorite here, wall slide. Dr. Kowalski touched upon this one as well. Just do it at least 3 times a day. I do it 3 times a day. If I'm working on the computer, get against the wall and just do some wall angels. Great, 10, 15 reps, great exercise. You want to make sure the key is you want to squeeze your shoulder blades together when you're in the bottom part of the exercise. All right, stretches for the hamstrings. Sit a lot, your hamstrings get tight, right? So here's a beginner stretch, just on the chair, intermediate on the block, and then you can graduate to the either narrow or wide hurdler, right? So this is a wide hurdler exercise right there, a little bit more advanced. Piriformis stretch, or piriformis muscle that goes from the sacrum to the outer hip, right? Sometimes you can even pinch and irritate your sciatic nerve. You may get some pain down the leg, down into the hamstring. Again, simple stretch on the left on the chair, graduate to the figure 4 stretch, and then to the pigeon as you get better. And the hip flexor stretches, right? The simple runner stretch on the left, and then a lunge stretch, a little bit more advanced. And once you get there, then you can bring the arm on the same side that you're stretching the hip flexor. You bring it down and lean to the opposite side, and that stretches your hip flexor even further, right? And distress, don't forget to distress. Lower stress helps the back pain. Daily mindfulness practices, practicing gratitude, meditation, yoga, breathing exercises, help the mind, help the body, help decompress. Thank you for your time and your attention. You can follow us on Twitter, and for more information, you can come to onsmd.com. Thank you for your attention.
Okay, I think I'm back. I'm busy stretching. Thank you. This is I know I'm not doing it right because I'm sitting, but I have my hands in the back. It's amazing information, really very, very useful. And now we're moving to the hand, wrist, and elbow. So I'm pleased to introduce Dr. David Way, who MD, MS, is a board certified orthopedic surgeon and fellowship trained specialist in the evaluation and treatment of hand, wrist, and elbow conditions and injuries. He is surgically skilled in microsurgical nerve reconstruction, arthroscopic treatment of wrist and elbow disorders, tendon reconstruction and repair, and endoscopic treatment of carpal tunnel syndrome. We're all at the computer a lot, and I know that's a real issue. His expertise includes diagnosis and treatment of conditions of the upper extremity in both pediatric and adult patients. These include arthritis of the hand, wrist, and elbow, fractures, sports industries, nerve compression syndromes such as carpal tunnel and cubital tunnel syndrome. I can't pronounce the next one, contracture, trigger finger and trigger thumb, bicep and tendon and triceps tendon tear and ruptures, tennis elbow, and ganglion cysts. It's my pleasure to introduce someone who's my husband's doctor, Dr. David Way.
Thank you, Marcia. I really do appreciate everyone's time. I know everyone's time is very valuable, and it's also lunchtime, so hopefully everyone is having a good lunch as you're watching. I'm going to share my screen here, and I know we have a hard stop at 1, so we're going to try to get through these slides as quickly and as efficiently as we can. We've already had 2 great talks. I think we've heard from our sports doctor and also our spine and physiatry doctor. Today, we're really just going to focus now on the hand, the wrist, and the elbow. And many of you know this is probably your daily life. If you're lucky enough to have a Peloton, staying fit at home is not easy. I think getting on a bike like the Peloton is almost a luxury if you have it. Some of us have treadmills at home. Many of us even have newer technologies like these mirrors that have all sorts of screens on them. And we're all trying to stay healthy because, it's been tough, mostly because many of us who do have the privilege of even working at home have a hard time. We're struggling with kids. We're trying to find space and trying to find the right position and time, and also juggling all these things that we usually do at home, but now in a different environment. We're trying to bring work into that environment. I know many of this is everyone's daily life, but what I'd like to focus on is really just 3 things. So we're going to keep this very short and sweet. I'm a hand, wrist, and elbow surgeon, so I thought I'd give you just those 3 top tips for you. So we're going to focus on the hand first. And if you think about the hand, one of the things that we often see, I've seen it already 4 or 5 times this morning, are trigger fingers. And trigger fingers are really a problem because when you're doing things, oftentimes things that require gripping, you can cause a trigger finger. Nobody knows why you get it, but we do know that repeated gripping can really be a problem. And if you're doing the things that we think about at home, like working out, grabbing weights, holding that Peloton bike handle, doing dumbbell curls, all these things require gripping and can increase your chance of getting a trigger finger. So number one, just be aware of it. Now that you know what it is, there are certain options to really kind of reduce it. Inflammation is really the key here. So when you think about problems with your hand, most of it is to do with inflammation. So using things that are anti-inflammatory are the key here. Advil, ibuprofen, they can all help. If it gets too severe, then you're looking at something else like a cortisone injection. But really taking frequent breaks and not overdoing those heavy gripping exercises is really key. So trigger fingers, hand problem, anti-inflammatory, think a lot of breaks and don't overdo the gripping. We're going to talk about our next problem, which I'm going to focus on your wrist. So by far, carpal tunnel syndrome is one of the things that we see most often as a hand surgeon. And carpal tunnel syndrome is rampant now because everyone is working at home. And really the reason is this, everyone has some sort of keyboard they're on, and there's a lot of focus on ergonomics. And ergonomics, I think you're going to find all sorts of tips on the internet. I think the key here, though, is you really want to reduce the impact, the pinching of your nerve. And that's really what carpal tunnel is. So all of these tips here that you might see, the whole purpose of this is really to think about how you position your wrist so you reduce the amount of pressure on your nerve. And by definition, there are certain risk factors that make it worse. So we already know about computer work, which people used to think was a myth about carpal tunnel, but really has been proven to be true. But there are all sorts of other things you might be doing around the house that are making this worse. So a lot of you are probably thinking about going out to garden, or maybe even using your hands more around the house. So when you do those activities, you could be increasing your chance of carpal tunnel in addition to all the computer work you might be doing. So it's really important to make sure you reduce the risk factors as much as you can. Carpal tunnel, again, is compression of this nerve, and you'll see this yellow structure. That's really the problem here. And for many people, it's confusing what it really feels like, but carpal tunnel can both be painful, but also numb and tingly. So if you have numbness and tingling in your hand, that's a good reason to come in and see me or see somebody in our group for this problem and really figure out if that's your problem. The real reason why carpal tunnel might affect your fitness is because if you have it and you ignore it, you might actually start to see some muscle loss. So in the bottom right picture, you're going to notice a left hand that is normal and a right hand that suffers from this atrophy after having ignored severe carpal tunnel. And of course, if you have atrophy or muscle loss, you're going to have a weaker grip and it's going to interfere with any of your activities. So surgery is a last resort, but I thought I would just share that nowadays we do it endoscopically. I do all my carpal tunnel surgeries endoscopically. It's a nice way to treat this with a smaller incision. You still get great outcomes. In fact, you usually can heal faster endoscopically than open. Something to think about when you're considering surgery, but oftentimes we treat this, most of the time we treat this without surgery. All right, let's get to our last point. So we've talked about the hand, we've talked about the wrist. Now let's turn our attention to the elbow. The elbow, one of the most common things I see, especially as people are getting back to activity, is tennis elbow. And tennis elbow is a misnomer, really. You can certainly get it from tennis, but it's really any kind of racket or club holding sport. So you don't have to be, a famous tennis player or a famous golf player, but think about this. You don't even have to really play tennis to get it. Golf players get it. If you happen to be a polo player, you might even get it. Anything where you're holding something and you're using your wrist, you can get tennis elbow. So it is very common. It almost always goes away on its own. And, one of the best ways to really avoid this, again, is really trying to take a lot of breaks and actually do a stretch. And we've already seen some really great stretches for your shoulder, for your back. I'll add one more for your elbow. The best stretch, I think, for tennis elbow is making your elbow straight and then bending your wrist down and pulling on it and then rotating it outwards. And that really helps stretch those tendons that are involved in tennis elbow. And if you hold that for 10 or 15 seconds, you work on that, you take breaks from your work and you do that, I think you can really mitigate how much symptoms you get from something like tennis elbow. These are the tendons we're stretching. I apologize if you're eating right now and you're looking at these pictures, but I just wanted to show you it is really linked to your anatomy. Many options for treatment. One of probably the most interesting ones recently is something called PRP, which Marcia had mentioned before. It's a platelet-rich plasma injection, something that has some effect and probably pretty good effect, but we can talk more about it in the office if it ever comes down to that. So a lot of different options for tennis elbow, but the key here is stretching, not overdoing your racket or club holding sport, and just remembering it really does go away on its own. So, 90% success rate if you wait long enough. All right, so I kept it short. I just want to summarize. We have had 3 topics, hand, wrist, and elbow. We covered something called trigger fingers, which is very common, carpal tunnel syndrome, which is also very common, a problem with your nerve, and tennis elbow. And I also want to show you one last picture here. Ergonomics, especially when you're working at home, is key. Making sure that you have good posture, making sure your wrists are straight, and then making sure you take breaks and be kind to yourself when you're trying to work at home. All right, thank you, everyone.
Okay, I'm busy stretching here, doctor.
That's
I
the
hope
stretch. That's the stretch.
right?
You got it,
Okay.
Marcia.
The stretching is key, we know. Thank you. I have to say, this is really amazing and very, very useful information as we all sit at our desks and type and multitask, and really appreciate it. So our final presenter is Dr. Mark Yakovonis. He's an orthopedic foot and ankle surgeon. I'm not going to show my feet and ankles at the end, I promise. He's board certified, fellowship trained orthopedic surgeon who specializes in the diagnosis and treatment of foot and ankle conditions. But boy, did they hurt a lot, right? And maybe they hurt a little less because us women aren't wearing high heels these days, which has helped. His expertise includes sports injuries to the foot and ankle fractures, syndesmotic and cartilage injuries, Achilles tendon injuries and tendinitis, foot and ankle arthritis, and minimally invasive and arthroscopic surgical techniques. Dr. Yakovonis is experienced in ankle joint replacement surgery and neuromuscular disease. Doctor, make us feel better and have our home phones stop ringing during a webinar. That would really help, but that's not what you do. So focus on our feet and ankles, please.
Okay, thanks, Marcia. So let me just bring up my talk here. Well, thanks everybody. I'm going to be brief let's see. And I'm going to just talk about how you can avoid ever meeting me in person. And so, getting back on your feet, there are a lot of conditions, and I think a lot of the guys touched on issues you can develop from going from inactivity to activity. And I'm just going to talk about how you can navigate those waters for your feet and your ankles. There are a lot of roadblocks that I see in the office: Achilles tendonitis, plantar fasciitis, peroneal issues, stress fractures. I think a lot of that's beyond the scope of this talk. And what you really want to know is how can you avoid meeting me in person? And I'm not a bad guy, so if you meet me in person, I think you'd be happy. But let's talk about the 3 things you can do to stay out of my office, and that's modifying your activities, wearing the proper shoes, and stretching. And these are all hallmarks that have been touched on with each of the prior talks. So the root cause, particularly in the foot and the ankle, is repetitive loading. So it's cumulative steps throughout the day. It's the force you put on your foot as you walk, and that's mass times acceleration. So your weight matters, your footwear matters, and then the surface you're walking on or running on matters. And then also the posture of your foot. So I often have a little bit of a talk with patients. So when I tell you to modify your activities, I'm not telling you to decrease your activities. I'm just telling you to modify. So If you run and you're starting to have pain, consider going cycling, consider swimming. It's just modifying activities. I'm not telling you to stop your cardiovascular activity, but just modify while you're having pain. Also, you want to decrease the total time on your feet. So if you're standing at a desk as you return to work, maybe you can try to sit down for a little bit during the day, or maybe there are ways you can modify your activities just, to keep you on your feet and painless. A big part of this is decreasing the force you see through your foot. So that's weight loss. That's also modifying your shoes, and we'll talk about proper shoe wear. And then also modifying the surfaces that you walk on. So if you're running on concrete or you're running on pavement and you're starting to have some pain, well, maybe if there's a track nearby, you might want to run on the track. If you're walking or you're hiking on uneven surfaces, well, maybe walking on a stable surface like pavement might do you some good. So again, it's modifying, not decreasing. And as always, Alex touched on a lot of this, but core strength and balance, believe it or not, has a huge impact on your ability to walk and run painlessly for your feet. So what is the right shoe to wear as you return to activities? Well, this top shoe gives me heart palpitations. Minimalist shoes were very popular probably about 10 years ago, and they are the worst things you can put on your feet. So the way this model scrunches up the shoe just shows there's no stability whatsoever that this shoe is giving you. Really what you want is a rigid sole with a cushioned heel, slight heel elevation, and a soft and supportive shoe. So again, what you want is a comfort shoe, and there are a few different things you need for this. So one is a proper fit. Most people know how to get a proper fit in terms of lengthwise. The importance is width, right? So if you have a narrow foot, you might need a narrower shoe. You might need a wider shoe if you have a wider foot. That's fairly straightforward, but a lot of people are just buying things online and aren't properly trying on their shoes these days. So it's something to consider. And if you're starting to have pain, you need to analyze, are my shoes properly fitting me? You also want a stiff sole. So in that first clip, I showed you that they're able to scrunch up the sole of that shoe. That is not what you want. So a minimalist shoe is, some people are able to get away with it because of great genetics, but most of us aren't. So what you really want is a thicker sole that you can see here on the bottom left, that if you tilt it, you really can't bend the sole at all. Interestingly, you do not want it to be a firm sole. You want it to be cushioned. So you want a stiff sole that is cushioned and properly fitting. Some people will need shoe inserts. Now, if you have a painless foot, you shouldn't have a shoe insert. But if you're starting to have pain, oftentimes by putting an insert into your shoe, it can alleviate a lot of the stresses that you're seeing. So this is where it gets a little bit difficult to recommend on, over the Zoom call, because it depends on whether you have a flat foot. If you have a flat foot, you want something that's going to support your arch and decrease stress to the structures on the inside of your foot. Conversely, if you have a very high arch, you want something that's going to have a tendency to tilt you out and even you up to decrease the stress on the structures on the outside of your foot. It's intuitive, but it makes a lot of sense. Lastly, we want to touch on, and this is a big issue for a lot of people, when you return to activity, you have a huge problem with your Achilles. So your calf gets very tight with inactivity, and you really need to stretch that because a tight calf can lead to numerous foot and ankle conditions. Even in your forefoot, you can overload it with a tight calf. You can develop plantar fasciitis, Achilles tendonitis. So it's very important to stretch your calf. And it's very simple, right? So for 5 minutes a day, whether or not you divide it up into 2.5 minutes in the morning, 2.5 minutes at night, you just need to stretch your calf. And this is what you need to do, right? So you need to put your back leg and you need it to be straight. And you also need your hind foot to be relatively straight, because if you do that, you're going to properly stretch your calf. And if you stretch your calf, you're going to be able to get back to activities painlessly. So I know that's a whirlwind tour, but the hallmark for the foot and ankle is just make sure you're stretching your calf. You can't do it if you don't do it daily. It's the thickest tendon in the body. You need to do it multiple times throughout the day. So stretch your calf, wear the right shoes, and modify your activities if you start having some discomfort and get back in a stepwise manner. All right, thank you.
This has been absolutely amazing, amazing, and so helpful information. We do have one question in the Q&A. What is the best way to train, exercise an imbalanced spine with mild scoliosis?
Well, mild scoliosis, great that it's not severe, right? So really just the core strengthening, right? But again, what I touched upon in my talk, Dr. McGill's exercises, not only just to strengthen the core, but also to build the endurance, right? And we talked about stretch. I mean, really just a well-designed, well-rounded exercise routine, right? So if you do have some back pain, I would certainly recommend starting working with a therapist, right? So that's where you want to start. You want to start with a therapist, and then you will progress to, if you feel comfortable, things going well, you can progress to exercising on your own, or you may need help with working with a personal trainer, right? Or an athletic trainer. And they can really take you, or, so transition you from structured physical therapy to exercising on your own. And that's where you want to be.
Let me see if there's another question here. Okay, I think that's it. Doctors, you have provided amazing information, and you are amazing, amazing professionals. And ONS, we're so pleased that ONS is our member and is an active and wonderful member of our community. I know we had a rising star last year from ONS. We're very, very proud of that. And what we love about your approach and the information today is that you are all about starting with preventative and starting with staying healthy. And that's the culture of your organization. And then if people need more help, you are there to help them. So we appreciate everything that you do. We appreciate your professionalism. We thank you. We thank our participants for listening and for your questions. We're getting great comments right now. And we want everyone to stay healthy with all of your joints and your wrists and your elbows and your knees and your shoulders. And we ask everyone and your feet and your hands, and we ask, what did I leave out? And we ask everyone to still please wear your masks. It's still tough out there. We're in the final stretchers. Final stretch and final stretches. So let's all keep healthy and take care of each other. Have a great day. Thank you, ONS.
Thank you, Marcia.
All right. Thank you so much.
Stay safe.
Have a good day, everybody.
You too. Thank you.